All right.
All right. So, I'm Susan. And Jax had asked me to make sure that I told lots of stories. This is all about storytelling, so what I'm going to do is I'm going to tell you a couple of stories about designing for well-being in India. So I'm going to take you on a whirlwind tour of a couple of the initiatives that I've been involved with over the past few years now. And I should also say, Jax introduced me as being from San Francisco, and yes, I don't have an Australian accent. And I have a company in San Francisco, but I also have spent the last 19 years working in Australia. And so I do a lot of work around here. And one of my students is probably going to wander in a few minutes. He actually heard me go through this talk today, so he already knows what I'm going to say. So that's why he probably figured it's okay to be late. Anyway, so what I'm going to do is I'm going to tell you very quickly about two projects. And I was hoping to go last because I actually don't know that I can do this in 10 minutes, so I'll talk real fast.
No, make it 15.
Okay, cool. All right. So I'm going to talk about two projects. One's called RAXA, and the other one that I'll talk briefly about is called Bayou. And to set the stage, I want to start by showing you the first minute or so of a video that we made actually about the RAXA project. Because the issues that we addressed, that we are addressing in RAXA is pervasive to a lot of healthcare issues that we're facing in developing countries, rather. So I think it just kind of sets the stage nicely. If I can get the technology to work properly. And I click over here. I think you actually...
Hi, my name is Dr. Shurajeev Nandi, and I'd like to tell you about RAXA.
Can you hear that?
Yep.
Health systems can make one healthy, but an overstretched health system, as is true in most developing countries, is bad for a citizen's health. This is something that affects many people across the world, but the situation is considerably worse in developing countries. Most people there have little chance of regular, healthy contact with their system. It is too expensive for developing countries to change this. Too few providers are trained with good information, and patients are left uninformed and thus unempowered. In healthcare markets, this asymmetry in information between healthcare providers and patients contributes to healthcare-related costs, being the leading cause of people falling into poverty. But what if there were another cost-effective way to inform patients, to connect them to providers, and to improve access to healthcare without increasing the number of providers or dramatically improving facilities? At RAXA, we believe that this is possible using technology. We're building software that helps overstretched providers be more efficient and empowers patients by giving them greater access to their health information.
Okay, I'll stop that there. So that's the context in which we're working. Here's just a bit of an aside. I should say that I have the fortunate, and I'll be talking a lot about what I did when I was in India, but this is just the first of many diversions. And this is one of the many discoveries that I had, is that India is really big on sweets. They're also really big on politics, because we were there at the time when it was the lead up to the election, and so everything was about the elections that were coming. And here we get to even combine the sweets and the politics. Another thing I should tell you, if you're not aware, is the fact that India is one of the fastest growing markets for the use of mobile phones. So they aren't necessarily smartphones, although cheap smartphones are coming. And we do see a lot of people using smartphones, but there are a lot of telephones. And so our idea was that we should be able to leverage some of this technology in an effective way. So the way the RAXA project started is with a TV show, actually. So there was a TV show called Dr. ND TV, New Delhi TV. It was probably one of the first reality TV shows about healthcare, and it was people calling in and getting advice from doctors about what was wrong with them. And that ran for a long time, and one of the things that happened was the information that got collected by a number of doctors was compiled into a website for the show. The show eventually met its demise. There were more interesting reality shows that came along. But the IP for the information that was collected was acquired by my buddies at RAXA. And so that was actually the start of it. So the project actually began with an online resource. That was part of what started the project. The other thing that started the project was this organization. This is a hospital a name which I cannot pronounce in a location that I cannot pronounce. So we'll just call it JSS. And what JSS was a very progressive bunch of health professionals who were really interested in delivering health care to very rural parts of India. So they had a model where they had doctors in a clinic, much like this, and what they would do is they would go out and they would have a lot of people come to the clinic for a few days of the week, and other days of the week they had community health workers out in even more remote areas, and they would work with these community health workers to deliver health services to the backwaters of the backwaters of India, to get health delivered to these people. And they were quite committed to this, and they didn't take much money for it, and it was all a very good opportunity to do good in the health community. They had come to us and said, we need some new technology to help us be more efficient. And so that was an interesting challenge for us because we were in the business of trying to think about ways that we could support them. And one of the things that we wanted to do was give them some technology that would help them automate processes and do things in a more efficient way, and be able to record information better about the patients, and perhaps be able to share information with patients. Because remember, I said everybody and their dog has a mobile phone in India. So even people who are illiterate use mobile phones, and there was a way to share medical information, by virtue of pictures and things like, and numbers and things like that. They were numerate, they weren't necessarily literate. So the idea was, we thought of all these great things that we could do to actually support these people. Unfortunately, we also ran into some problems. One of the problems was this location happens to be about 1,500 kilometers away from New Delhi, where all of our developers and designers were working. So there was this distance problem. We couldn't actually hang out with them very often. The other problem was they weren't really keen to change their processes. So we were sitting there scratching our heads saying, maybe this isn't the best use of our time. As much as we would love to help them, maybe it wasn't the right time for us to be involved with them. So while their needs are very important and they've continued to drive our thinking, we decided that perhaps it was best if we didn't work with them right away. But we will come back to talk about them in a few minutes. So instead, what we did was we turned our focus back to more of the urban environment, where we saw doctors having a real interesting challenge in keeping medical records. Because one of the other things that we learned about in India is the fact that medical records are very different than we're accustomed to. If you go to a GP, for instance, what you'll find is that your GP will not keep any information about you at all. They will take whatever they write and they will hand it back to you. And so it's your responsibility as a patient to carry those records around with you to whatever doctor you go to. Now we might say that that's a good thing, because that way we're not, we have control over our health records, but it's also a very challenging thing to be able to keep all these things, right? Especially if you don't, if you have a filing system like some of us do. So we decided we wanted to tackle a different problem, which was figure out how we could better support doctors in places like hospitals. So we were very fortunate to find ourselves some really good friends in a hospital called Sir Gangaram Hospital in Delhi. And what we were able to do is get them to invite us in and have them help us identify how we could deliver a solution that might work in the hospital setting. So we got to do wonderful things. I got to spend time going around making the morning rounds with the doctors in the hospital. I mean, this was something I could never imagine having been able to do. My American sensibilities about security and privacy and all the legal aspects were like, there's no way I'm going to be able to walk around in a hospital, and tag along with these doctors. But I did it for every morning we were working with these guys. And even more so, I got to go into ICU, which I thought was really amazing. And so some of the things that we saw were not just about how they did their work, but it was also about all the reams of paper that they had. It was about the things that they had to record. It was also about how they interacted or didn't with the patients. Because one of the things that we were very concerned about is if we're introducing technology into that setting, is it going to become a barrier between the doctor and the patient? And we didn't want that to happen. So it was really important, and we learned a lot by hanging out with these guys. Also, like every good consultant, I hung out at Starbucks. because of the free Wi-Fi. And you know what? That is a really cool Starbucks. I mean, you've never seen Starbucks like this. But it was a really convenient location for us to be able to take advantage of their free Wi-Fi when we were between visits, and so that was a good thing. We also spent time going to smaller clinics as well. So we, not just thinking about hospitals, but we wanted to think about other environments. So we had to understand what life was like in small medical clinics. This was a fascinating place. This was a family care center run by a single doctor with 5 people that worked with him that were support staff. In this office, they saw, well, we were there, one time we were there for like 2 hours, and they saw over 80 patients in 2 hours. It was just amazing that they could even do that. But they, it's like a conveyor belt, right? And they get them in, and they talk to them, and they give them a prescription, and they send them on their way. And what was interesting about that is one of the things that we discovered is every single patient gets a prescription, no matter what you go there for. And it's not, I mean, we might say it's about over-medicining, that's not a verb.
Medicating.
Over, what's it?
Medicating.
Medicating, that's the word I was thinking of. But it's about the fact that people felt disappointed if they didn't walk away with a piece of paper. I've never heard of this. So, maybe they were writing placebos, but they had to write something and give you something. So that was one of the interesting things we learned. We also learned some other interesting things, like the fact that this was the environment where, this was HQ, right? This was their environment where you notice there's a lab technician who's studying the samples. Here are some samples. This was the woman that was dealing with all of the finances, sitting, shoulder to shoulder with the woman who was looking in the microscope. And meanwhile, they would talk to each other. Sorry? 2 minutes. Okay. Anyway, they were doing all kinds of interesting things, and that, by the way, was their IT department over there. We also learned that the internet isn't quite as reliable as we're used to, and that was something to consider. And we needed to account for that. It's chaos. And we can't use our first world sensibilities in an environment like that. It was really important for us to be thinking about what was going to work for them. I mean, this is some stuff we teach all the time, but when you're actually thrown into a situation like this is what you learn. So it was beholden on me to think like a native, right? So this was an opportunity for me to go and really immerse myself in the environment. And this is what it's like in startup land in India. Kind of looks like startup land anywhere. Notice there's lots of sweets there, even Dunkin' Donuts. But this was the startup environment. And one of the first things I made us do was write a bunch of scenarios, and you don't need to read what's on this slide, but just the whole point of creating scenarios are to make sure that we were really clear about being able to articulate what it was that we were trying to accomplish, and make sure that we could use that to validate and then drive the design of some solutions. We did lots and lots and lots of sketching. We did co-design with the development team. We went and talked to a lot of early adopters and showed them what we were up to. We had and still have weekly and very lively co-design sessions with the intended users. So these are people who are actually already using our system as we're trying to refine it. And so that's really cool. We'd get together on Thursday afternoons, would have these great meetings. Some of them didn't always go so well. And we learned some really, really, really important things. And one of the main things we learned was we had this brilliant iPad solution because we weren't trying to emulate the writing on their notepads because we thought that was what they said they wanted. But then it wasn't until they used it for a while they realized, you know what, they don't want to carry around iPads. They had no place to put them. They were afraid they were going to drop them. The stylus they were always losing the stylus. They were afraid they were going to grab their ballpoint pen and write all over the iPad. And the whole point was we decided that was not going to work for them. But what these doctors were doing were carrying around smartphones. So we had to change our whole approach and go to smartphone technology. And that was something that really has worked in our favor. We then kept on refining it because we realized that we still wanted to have a hook because we wanted to get these other people using the system. We wanted to get different, it was working for the hospitals, but it wasn't necessarily yet working for the small clinics. And we hadn't even started tackling how we were going to address the patient-facing side of it. So we spend a lot of time in front of whiteboards and fast and furious with the eraser to change our minds about what we're doing. Going out and looking at other opportunities. So this is another great opportunity where we could help people who are actually professional carers, who are supporting people who are in the later stages of cancer, as well as also focusing on the professional carers as well as the family members, and that was just a real nice solution. One of the things we found was we're coming up with the skeleton of a really nice picture of what we can deliver for these medical professionals. One of the things we find, though, is that our design process, we talk about when we do any kind of design, we talk about the fact that we usually start broad and come up with a whole bunch of ideas and then iteratively refine and then hone in on something. So that's sort of our ideal process. I'd have to say that our process probably ends up looking a little bit more like this, which we had a bunch of focus up front, and then we are going out like this. And I think in the interest of time, I'm going to stop there. That's the first of the two projects. If anyone's interested afterwards, I'm happy to talk to a few of you about the second project. So I'm going to leave it there.